This is May 28th, 2024. We're recording this for the future. So if you're watching this at a later date to receive CE credit, please scroll below the video player to the instructions section. Number 2 is the handout, and number 3 is the quiz. Okay, so your CE credit instructions for this evening in your handout, and I hope you have it. There is the link. At the end of the presentation, we're going to be giving you a passcode. Be sure that you're here for that passcode. It'll only be announced one time, and we'll have it on the screen as well. After the course ends, we cannot provide it. It's a way to secure your attendance and be able to demonstrate that you all are here. All right, so make sure that you're here. We're not emailing the quiz. It's there for you right in the handout. If you need assistance, please reach out to us through that link. All right, our learning objectives for this evening: discuss the scope of the opioid problem, discuss the role of the dental clinician, review prescribing recommendations by the American Dental Association and other organizations, and demonstrate strategies and alternative modalities to reduce opioid prescribing and abuse. So the ADA statement in May of 2019, almost May 25th, right? Today's May 28th. To combat opioid abuse, the ADA has urged all 163,000 member dentists to double down on their efforts to prevent opioids from harming patients and their families. So I practiced in public health for the majority of my last probably 14 years of practicing, about 32 years. And some of us have a preconceived notion of what the patient is, the drug-seeking patient or the patient that may have problems with substance abuse disorder and so forth. And I want you to put away those preconceived notions this evening if you can, because we're going to find that many of the patients we need to be concerned about also are the ones that have had no experience with opioids. And I have a first-degree relative that actually happened. My grandmother, who had surgery. She was 61 years of age, had surgery, and was prescribed Vicodin. And 4 months later, she went to bed and didn't wake up in the morning. She died of an opioid overdose. The autopsy revealed that she had overdosed on Vicodin. And this is a problem for many of the patients that we have. Again, when we are prescribing, we have to realize that this situation can really happen to any of our patients. Now, the American Dental Association now supports considering prescribing nonsteroidal anti-inflammatory drugs, as we'll talk about, alone or in combination with acetaminophen over opioids as first-line therapy for acute pain management. And there's a link to the ADA statement there. So when we discuss the problem, this study is important to review. This was a study that looked at trends in national opioid prescribing in patients enrolled in Medicaid, dental patients, 2012 to 2019. Consistent decreases in opioid prescription rates in dentistry were noted during this time of 2012 to 2019. From 2.7% to 1.6% among children, and they deemed children 0 to 20 years of age, and then from 28.6% to 12.2% for adults 21 to 64 years of age. And for adult opioid prescriptions, the rate decreased for non-surgical dental procedures from 9.7% to 2.9%, which is pretty remarkable. For surgical procedures, the adult prescription rate decreased from 48% to 28.7%. However, it's not good enough. Most dental-related opioids were prescribed for oral surgery, so children 70.8% and adults 58.6%. By the year 2019, 23% of all opioid prescriptions for children were dental-related. In 2012, 255.2 million opioid prescriptions were written in the US at an annual rate of 81.3 prescriptions per 100 persons. Now, in 2019, that decreased to 153.3 million, or 46.7 prescriptions per 100. Still not good enough. Opioids, both prescribed and illicit, were the leading cause of drug overdose deaths in 2017, according to the CDC, involved in 47,800, or 68% of all overdose-associated deaths. And the total economic burden of the opioid epidemic from 2018 to 2020 alone reported to be at least $631 billion. And that's cited by the Society of Actuaries. There are a couple of you that note your audio is an issue. Our audio is fine on our side. We have an engineer on every one of our classes. If you're experiencing audio issues, first be sure you're using Chrome browser and updated Safari. Also, you can try logging in and logging out. If you're on a phone, it may be your connection. The opioid handout for the class, tap on the red banner at the top of the screen. It is also in the chat area for you, and you can tap directly on it or cut and paste in a browser. Dentists are among the top prescribers of opioids and top prescribers for patients aged 10 through 19. Patients receiving oral health care in an emergency department are more than 7 times likely to receive an opioid prescription than were patients treated in a dental office. And antibiotics, I might add. The 7 is not the correct answer, but those two in combination. Among all dental procedures, surgical, implant, endodontics were associated with the highest rates of opioid prescriptions, and more than 1/2 of all dental prescriptions remain unused 3 weeks after a dental surgical extraction and may lead to non-medical misuse, sitting in somebody's medicine cabinet. Among adolescents, young adults, dental-related visits are often their very first exposure to opioids. 11.2% of dentist-prescribed opioids were written for patients under 21 years of age. Young adults, high school exposure, 33% more likely to misuse opioids in the future. We're going to review the CDC clinical practice guidelines because we're required to, and the latest guidelines were 2022. Now you have a link here. You also have a copy of that in your course folder to download. So you'll have 2 documents in that course folder: my presentation that you see here and that document. And the next link here, recommendations for management of acute dental pain. And this is through Indian Health Services. It's a very good document, so I included that for you just for resource. What do we know about the 2022 recommendations compared to 2016? It expands the guidance for acute and subacute pain, and they identify acute pain as less than 1 month's duration and subacute as 1 to 3 months duration to help primary care and other clinicians, so surgeons, oral health practitioners, emergency clinicians, weigh the benefits and risk of opioids and other pain treatments for outpatients. So the original document, 2016, really focused on chronic pain, less so on acute pain. And in dentistry, much of the pain that we are managing is acute. Not all of it, but much of it is, right? Post-operative pain or pain due to infection. So the guideline really didn't align well for oral health practitioners. So they've updated it, they've expanded it. In addition to updating those recommendations on the basis of new evidence regarding management of chronic pain, the newer guideline was intended to assist clinicians in weighing benefits and risks of prescribing opioid pain medication for painful acute conditions. And then they go on to identify what those are, including dental pain and post-operative pain, particularly from oral surgery. The guidelines to opioid prescribing through the CDC guidelines include the following. Patients have access to safer, more effective chronic pain treatment, reduces the number of those who misuse, overdose from these drugs, and reduce the number of harms and deaths. Provides recommendations for the prescribing of opioid pain medication to patients 18 and older in primary care settings. More than 11.5 million Americans aged 12 or older reported misusing prescription opioids in 2016. And we're going to look at more recent data. Again, that is from the CDC's. But what we do know is despite the misuse, despite the increase in use, 11% of adults experience daily pain in the US. Millions of Americans are treated with prescription opioids for chronic pain. Primary care providers are concerned. However, the amount of opioids prescribed does not equate to managing the pain in any more successful way, if you will. The pain that Americans report remains unchanged, despite the fact that from 1999 to 2014 alone, opioid prescriptions quadrupled. You might see that on a quiz. Okay, overdose. Since 1999, there have been more than 165,000 deaths from overdose related to prescription opioids. This is the latest drug overdose mortality map by state. And if you click on that link, it will take you to an interactive map where you can look at your state. And there are a couple here that really stick out, don't they? West Virginia, Tennessee, followed by my current home state, Arizona, etc. So not only can you see your state statistics in terms of drug overdose death rates, you can also go to another interactive map and it will tell you the percent change, whether positively or negatively. And then also the predicted 12-month ending count of drug overdose deaths by your jurisdiction. So those, again, are interactive maps just for your own knowledge, and you can tap on that and it will take you. That link should be clickable for you. Deaths by substance is another one. So this starts at 2019. Number one here is fentanyl. Fentanyl is really destroying communities around the US, followed by methamphetamine. And I'm talking about as of 2022, followed by cocaine, heroin, and then oxycodone and xylazine are neck to neck in terms of 2022. So the CDC guidelines stresses the patient-centered clinical practice. It includes conducting thorough assessments, consider all possible treatments, closely monitor risks, and safely discontinuing opioids. So number one, determine when to initiate or continue opioids. And again, this is from the CDC. So they start with chronic pain. Selection of non-pharmacologic therapy, non-opioid pharmacologic therapy, and opioid therapy. Establish treatment goals. Discuss the risks and benefits of therapy with patients. Number two, opioid selection, dosage, duration, follow-up, and discontinuation. The selection of immediate release or extended release and long-acting opioids, dosage considerations, duration of treatment, and considerations for follow-up and discontinuation of opioid therapy. Number three is assessing risk and addressing harms of opioid use. Evaluation of risk factors for opioid-related harms and ways to mitigate patient risk. Review of prescription drug monitoring program data. The use of urine drug testing, considerations for co-prescribing benzodiazepines, and arrangement of treatment for opioid use disorder. And if you're not familiar with the co-prescribing of benzodiazepines, that practice in the medical world was called V&V, Vicodin and Valium. So if somebody had like acute back pain or even chronic back pain, and back spasm, the idea was the Valium would address the back spasm and the Vicodin the pain. Calculating the total daily dose of opioids helps identify patients who may benefit from closer monitoring, the reduction or tapering of opioids, prescribing of naloxone, and other measures to reduce risk of overdose. So we'll talk about calculating the total daily dose of opioids for safer dosage, and that is also available to you on the slide, but morphine milligram equivalent is what is used. And so to calculate what's called MMEs, you'll multiply the dose for each opioid by its conversion factor, and the conversion factors are here. So you see the conversion factor for codeine, for instance, is 0.15, transdermal fentanyl 2.4, hydrocodone 1, morphine 1, oxycodone 1.5, and so forth. So to calculate MME, we're going to provide you with two examples. Example one, tablets that contain 5 milligrams of hydrocodone and 300 milligrams of acetaminophen taken 4 times daily would contain a total of 20 milligrams of hydrocodone. And the conversion factor is 1 for hydrocodone. So the MME would be 20 MMEs daily. Example 2, extended release tablets containing 10 milligrams of oxycodone taken twice a day would contain a total of 20 milligrams of oxycodone daily, equivalent to 30 MMEs per day. Now, why is that important? First of all, realize that we don't use the calculated dose in MMEs to determine the doses to use when converting one opioid to another. When converting opioids, the new opioid is typically dosed at substantially lower than the calculated MME dose. Why? We have to avoid accidental overdose because of incomplete cross tolerance. You know, every patient's different, how quickly they clear a drug, and individual variability in opioid pharmacokinetics. And one more time, I do want to remind everyone that you do need the handout and the CE credit instructions. Tap on the red banner at the top of the screen. The quiz will not be emailed to you. The quiz link is in that handout, and I will be providing you with a passcode at the end. You do have to be here. Make sure that you're here and engaged. If you've just logged in, there's a little hand icon at the bottom of your screen. Make sure you tap on that so we know that you are here. Right now, we have about 40 of 400 that have signed in by raising their hand. So make sure At the bottom of your chat area, you should see a hand icon. If you don't see the hand icon, just type yes into the chat area. Okay, dosage recommendations. I'm sorry I have to take time out of the class for this, but this is a requirement for CE and our accreditation. So we do have to make sure we do our due diligence and that you're all here and engaged. All right, dosage recommendations here. The dosage recommendations for exercising caution are lower than previously recommended opioid prescribing guidelines. Higher doses of opioids are associated with higher risk of overdose and death. Even relatively low doses, 20 to 50 morphine milligram equivalents per day, can increase the risk. And that's important when we look at the dental data here. If we apply the MME to dental prescribed opioids, CDC guidelines that were released in 2016 for chronic pain management recommended no more than 10 milligrams of hydrocodone and acetaminophen tablets every 6 hours for 3 days. The maximum quantity converted to morphine milligram equivalents, MMEs, translate to no more than 120 MMEs total per day. A 2020 study based on more than 500,000 adult dental visits found that 29.3% of dental opioid prescriptions exceeded the MME-based recommendation, whereas 53% exceeded the recommended day's supply. Whoa. Previous guidelines focused safety precautions on the high-risk patients, right? Who are these high-risk patients? Let me go ahead and ask you all, who are the high-risk patients for opioids? The elderly, the benzodiazepines, those with chronic pain, anyone. Children, former users, addicts, teens, children, anyone previous addiction to opioids or alcohol, all of them, teens, patients that come in requesting pain meds, patients with a history, everyone, suburban moms, children. Okay. All of them. Now, we do know that those that tell us that they've had a substance use disorder in the past are definitely a high risk. I mean, they're telling us right off the bat, but really, we're going to see that patients that are opioid naive have just as great a risk to become opioid intolerant as the patients I used to see in public health clinics, right? When I was practicing in a very rural area, my local pharmacist on the weekends was also a dentist. He used to come into town and he would moonlight at the Rite Aid. He loved being a pharmacist as well. And he would call me up and we'd chat. And he would call me if I saw emergency patients over the weekend that I had prescribed an antibiotic and pain medication for. You know, we were very rural, and for oral surgery and so forth, if they came in on a Saturday or Sunday, we were, of course, going to address the infection. But if the patient walked out and only filled the prescription for the Vicodin, I would get a call. And that was my alarm that I knew I had a patient at high risk. That was really the only tool I had in my toolbox, right? We still don't have very good tools in our toolbox. So previous guidelines, again, focus safety precautions on high-risk patients. However, opioids are a risk to all patients. And currently available tools cannot rule out risk for opioid use disorder or other serious harm. The CDC guidelines provides recommendations on providing safer care for all patients, and the guideline also encourages the use of recent technological advances, like the state prescription drug monitoring program. I will tell you what that monitoring program looked like in 1982, 83, 84. When I was a registered dental assistant, we had a patient that walked in, a woman who claimed that she was visiting her mother. Her mother was terminally ill, cancer, and the patient that walked in was a nurse, and she was from out of state. She had a root canal that was started in another state. She showed us the periapical, the x-ray film, and she said that she was having some pain. So, of course, we saw her, took another x-ray, and the dentist wrote a prescription for her for Vicodin. And I was also temping. And a couple weeks later, I was in another clinic and working in the front, and the same patient walked in with the same story. And our monitoring system back then was the Dental Association, our local component. So if you knew somebody that was drug seeking, you could call it in, and that was all we had at the time for a drug monitoring program. So the new guideline here, 2022, provides more specific recommendations compared to the previous 2016 guideline on monitoring and discontinuing opioids when risks and harms outweigh benefits. The guideline addresses initiating and discontinuing use. When do we initiate or continue opioids for chronic pain? Opioid selection, dosage, duration, follow-up, and discontinuation, and assessing risk and addressing harms of opioid use. And the CDC developed the guideline using the GRADE framework. The GRADE framework, grading of recommendations, assessment, development, and evaluation. And recommendations are made on the basis of a systematic review of the scientific evidence while considering benefits and harms, values, preferences, and resource allocation. There are a couple of checklists the CDC's provided for you there too, and those links are in your handout. And again, they start with chronic pain. We, of course, are concerned about chronic pain, but we also definitely have patients that are experiencing acute pain. So the 12 recommendations are grouped into these three conceptual areas. First, when do we initiate or continue opioids for chronic pain? Opioids should not be the first line of routine therapy for chronic pain. We should consider alternative modalities. So for you all out there, what recommendations do you make for your patients that are non-pharmacologic for post-operative pain? Let's say for extraction. Ice, non-pharmacologic, so cold therapy, acupuncture. Got a lot of ice, TENS units, massage. What about acute pain? So non-pharmacologic means no medication. Now, I had oral surgery a couple of years ago. I had fractured number 3, vertical root fracture. It was a crown, and it was endo treated. It was still a simple extraction. It didn't require a flap to be performed, but there was grafting. And of course, my periodontist that treated me at the time does not prescribe opioids at all. So we alternated with the recommendation, right? I alternated between naproxen and Tylenol. And I was fine. But I can tell you when it started to wear off, it really tuned up. It was quite painful. So I'm not sure mindfulness and meditation would have done it for me at that point, to be honest with you. Chronic pain, maybe, but acute pain where the side of your head feels like it's going to just claw off, mindfulness was not going to be enough. But I bring this up because we don't really have that many tools in our toolkit. I'm going to provide you with some this evening. But when we talk about non-pharmacologic therapy, meaning no medications, no OTC, etc., what can we offer our patients? And there's not much. All right, clinicians should consider opioid therapy only if expected benefits, both pain and function, are anticipated to outweigh the risk to the patient. If opioids are used, they should be combined with non-pharmacologic therapy, meaning another tool in our toolkit besides medication, and I will be offering one up to you today. Establish and measure the progress towards goals. Establish treatment realistic goals with all patients, and consider how therapy will be discontinued if the benefits do not outweigh the risks. Clinicians should continue opioid therapy only if there is clinically meaningful improvement in pain and function that outweighs the risk to the patient's safety. Then we discuss benefits and risks with the patients and the responsibilities of both the clinician and the patient. Before starting and periodically during opioid therapy, clinicians should check in with the patient, discuss with patients the known risks and realistic benefits of opioid therapy. And responsibilities for both patient and clinician should be discussed for managing that therapy. All right, opioid selection, dosage, duration, follow-up, and discontinuation. When we start opioid therapy for chronic pain, clinicians should prescribe immediate release opioids instead of extended release long-acting opioids, and prescribe the lowest effective dosage. Use caution when prescribing opioids at any dosage. Carefully reassess evidence of individual benefits and risk when increasing the dosage to above or equal 50 mmes per day, and avoid increasing dosage to greater than or equal 90 mmes per day, or carefully justify decision to titrate dosage to greater than 90 mmes per day. Acute pain treatment leads to long-term opioid use. In fact, long-term opioid use often begins with treatment of acute pain. I gave the example of my grandmother. My grandmother couldn't fit any less the bill of whom I thought a drug-seeking patient was. She wasn't drug-seeking. She was tolerant. She was taking more and more, apparently. We had no idea. When opioids are used for acute pain, again, prescribe the lowest effective dose of immediate release opioids and prescribe no greater quantity than needed for the expected duration of pain severe enough to require opioids. 3 days or less is considered sufficient. More than 7 days rarely needed, and avoid concurrent opioid and benzodiazepine prescribing. These are the NIDCR dental recommendations. And when the 2016 guideline, CDC guideline came out, the NIDCR recognized that the CDC's guideline was lacking. It was not necessarily relevant to the practice of dentistry. So there were various current projects and initiatives that were carried on by the NIDCR with the objective to establish effective interventions or programs to manage, reduce, prevent opioid drug misuse, and align the opioid prescribing practices of dental professionals with scientific evidence. To meet the objective, the NIDCR would accelerate its research to establishing the efficacy, safety, and optimal medication course for analgesics to manage acute pain and implement systems to modify dental professional decision-making behaviors towards evidence-based recommendations for acute and chronic orofacial pain management, and promote the dental professional's role in screening for opioid use disorders and individuals at risk for opioid use disorders. Again, the problem as the NIDCR saw it, prescription pain medications, opioids commonly prescribed for the prevention and management of acute post-procedure dental pain. And an unfortunate consequence of that prescribing is the potential for misuse and abuse. Even short-term opioid exposure in opioid-naive patients is associated with long-term opioid use. Among persons with no opioid prescriptions in the prior 6 months who were prescribed at least 1 day of opioids, the probability of continued opioid use at 1 year is 6%. This was a prospective study of 12th grade students that were followed through age 23, suggesting that the use of prescribed opioids before high school graduation is independently associated with a 33% increase in the risk of future opioid misuse after high school among patients with little drug experience and who disapprove of illegal drug use. Dentists prescribe approximately 6.4 to 8% of opioid analgesics dispensed by outpatient U.S. retail pharmacies annually, and the highest percentage prescriber group for patients between 10 and 19 years of age. So the NIDCR looked at third molar extractions as a reproducible model. Most opioid prescriptions written by dentists for adolescents and young adults are usually to provide pain management for acute pain following third molar extraction. And those prescriptions may increase the risk for misuse, abuse, and diversion of prescription medication in that age group. Factors that impact our current prescribing practices, the lack of strong evidence-based guidelines for providers regarding optimal dosing schedules and length of time for which analgesics should be prescribed to manage acute pain following minor surgical procedures. So the third molar extraction model is a well-established model for studying acute pain and its relief because it's reproducible and it permits the study of healthy subjects without other comorbidities. The model has provided evidence of the good analgesic effects of non-steroidal anti-inflammatory drugs on the day of surgery, but the NIDCR recognizes that there is a need for studies that examine the longer term, up to 7 days, efficacy, effectiveness, and safety profiles of analgesics commonly prescribed for acute pain management following surgery. Now, stated earlier, the ADA notes that an overview of systematic reviews published in April of 2018 of JADA found that combinations of ibuprofen and acetaminophen were more effective at relieving acute dental pain with fewer acute adverse events. They concluded that the use of NSAIDs with or without acetaminophen covered the most favorable balance between benefits and harms and optimizing efficacy while minimizing acute adverse events. So the ADA recommends that dentists consider NSAIDs as the first-line therapy for acute management, anti-inflammatory analgesics. Now, these are examples of anticipated post-procedural pain levels according to dental intervention. And then prescribing recommendations, analgesics use according to that pain level, right? Mild, mild to moderate, moderate to severe, and then severe. Let's talk now about alternative non-pharmacologic dental pain management. Yeah, I totally agree with you, Gregory. I think it's important that patients understand the goal following surgery is tolerable pain, not no pain. I absolutely agree with that. And I can say, even after my surgery, and that was a humbling event because not only did I have the surgery, but I also developed Clostridium difficile from the antibiotics, but that's another course. I can't say that I had zero pain, but it was pain that I could live with. I could definitely manage it through the NSAIDs and the acetaminophen. And in fact, I did not even take as much as he wanted me to take through the course of the 4 days or so. I didn't need to. And I had quite a bit of swelling and bruising and so forth. But that's exactly right. We have to let our patients know what the expectations are. Okay. What should we do when a patient repeatedly reports to the office asking for additional opioid medication, citing pain? So let me ask the class what some of those answers could be. First of all, I haven't prescribed opioids. Now I haven't practiced clinically for about 2 years, but I've not prescribed opioids in over 10 years. I'm going to show you what I've used. And many of my colleagues haven't either. So the first step is not prescribing them at all. That would be step number one, so that they know that that's not something that you're recommending, because it doesn't align with the American Dental Association. What if they state they're still in pain and they want a refill? So again, that's when you have to check in with the patient. Alternative non-pharmacology, natural tea compress. Yes, I agree to reduce no pain expectation. Tell them to get meds over the counter, don't prescribe. NSAIDs, ask them to come in. That's what I would do. So there are many of you here stating that you do not prescribe opioids. Alternative non-pharmacologic dental pain management. I'm going to show you a video here. And this video is a congressional hearing here in the US. And the gentleman talking is Dr. Mel Birchman, who was one of the previous presidents of the Academy of Dental of Laser Dentistry, ALD. So laserdentistry.org. I'll let him tell his story. He became very involved with laser dentistry, and particularly photobiomodulation, following this tragedy. And again, these are experts that are at a congressional hearing. Annette Quinn is an expert on oral mucositis. She is a clinical nurse. Praveen Irani, Dr. Irani, is at the University of Buffalo. He is an expert on photobiomodulation, many publications and so forth. James Carroll is the CEO of Thor Laser, which is no endorsement of Thor Laser. It just happens to be that way. And I'm going to go ahead and play the video. And again, Dr. Birchman, I want you to listen very carefully to, and he is, again, the past president of the Academy of Laser Dentistry.
In February, I wanted to kill myself. I was taking 19 pills at night, and I looked at my husband and said, I don't think I can swallow another pill. I spent probably 20 hours a day in bed. I weighed 243 pounds. I could hardly move. And the doctors just kept adding more and more pills.
My son had a knee operation done. He was a really great athlete. And it was done about 2 years ago. And He was in constant pain afterwards. He wasn't talking to anybody about it. He went back to the surgeon. He said, everything looks great. Put him on some more Vicodin. Went back again. He says, everything looks great. Nothing I can do. Went to another surgeon. Looks great. I don't understand your pain. Gave him more Vicodin. Well, now Rob quit going to work, started gambling, abused Vicodin, and on February 27th of 2017, my son committed suicide by jumping off the George Washington Bridge, leaving behind a 4-year-old son and a 10-month-old daughter.
100 million adults in the United States are affected by chronic pain. $600 billion a year are spent on direct healthcare costs and lost productivity because of pain. Deaths from opioids, 49,000 people in 2017, and 19,000 of which were from prescribed opioids.
One of the most debilitating side effects reported by patients from cancer therapy is oral mucositis. And what oral mucositis, or OM, is it's an inflammation of the lining of the oral cavity, which leads to ulceration. Altered nutritional status is another issue that we see in these patients. They can't eat, they can't drink, and of course, extreme pain. You get a bone marrow transplant with high-dose chemotherapy, you're at 100% risk for developing oral mucositis. Approximately 500,000 cases of oral mucositis occur in the U.S. per year. In 2009, Medicare reimbursed over $40,000 per patient for ulcerative mucositis lesions.
So we know that light has an important biological role, but this particular treatment is called photobiomodulation, a non-ionizing source of photonic energy that generates non-thermal effects. We like the term photobiomodulation because we have noted that if you use the right amount of dose in the right context, we can stimulate certain positive processes such as wound healing and tissue regeneration. If you use the right dose in the right context, you can also inhibit certain negative processes such as pain and inflammation.
When we're sick, injured, stressed, or just old, we tend to be low on ATP, high in oxidative stress. When we put this light into patients, it tips the balance in favor of more ATP and less oxidative stress. And under these circumstances, patients get better more quickly.
There is a lot of studies out there on PBM for oral mucositis, and in the UK and in Canada and in Brazil, it is mainstay treatment for patients who are at risk for development of OM. There were 11 randomized placebo-controlled trials looking at a total of 415 patients, and from this consistent evidence of these high-quality studies, LLLT or PBM has shown consistent evidence that it significantly reduces and can even prevent oral mucositis in these patients. We have treated over 800 patients in my institution, and not one single patient that we have treated has ever quit therapy because they've said to me, this doesn't work, it's not helping. Not one. I mean, it's the opposite.
I can honestly say that using the Novathor
Okay, if you were not able to hear that video on your device, I put the link in the chat area. What we're talking about here is photobiomodulation therapy. It's low-level laser therapy. It is evidence-based. It's been studied for 40 years. And if you're interested in knowing more, the Academy of Laser Dentistry offers a standard level certification, and you can now provide photobiomodulation therapy using LED lights. So if you don't have a laser or you don't want to invest in a laser, there are FDA-approved devices that are available to you out there. You can talk to your dental distributor about it. It does reduce the need for opioid prescriptions, dry sockets. You don't get dry sockets if you use photobiomodulation. Even your patients that are smokers, you'll prevent many, many dry sockets by using photobiomodulation. Endo as well, it hastens healing. So you heard for oral mucositis, it is a wonderful treatment for preventing oral mucositis in many patients and treating it. I happen to be teaching a course tomorrow night on oral mucositis, and I'll be talking about photobiomodulation, It's used for oral facial pain, neuralgia, and more. So it can be used in the case of acute pain in many situations, as well as chronic pain, TMD, friends. Now, The link to the video that I just showed is right there for you. And if you go to, again, the Academy of Laser Dentistry or laserdentistry.org, you can learn more about photobiomodulation. We have additional resources here for you. For those of you that need updated on your antibiotic prescribing, while I have you all here, if you're still prescribing clindamycin, then you definitely need to be updated, because clindamycin is no longer recommended by the American Dental Association for antibiotic prophylaxis. So for your penicillin allergic patients, we have the co-author of the guidelines presenting on our platform June the 7th. It's a 3.5-hour course. It will not be recorded. The link is there for you in the handout. It is for dentists and hygienists. So if you'd like to attend, please be sure to register. We have additional free resources on our site, other courses as well. Those are just a few. Again, you do need the handout. I am going to go ahead and post it in the chat area for you. And you have, I believe it's page 5, the link to the quiz. We do not email the quiz any longer. It's included in your handout. I'm going to be giving you all a passcode in just 1 second. Any questions? We had a question about tramadol. Tramadol is an opioid. I'm not sure what your question is. Is it considered safe? Nope. And it's not considered safe, especially if you're patients that may interact with alcohol and so forth. Yep, you can look on the state map and find out what it looks like for your state. Insurance coverage of PBM. Betty, it depends. It depends. There are some dentists out there that are having some luck in terms of billing as a medically required procedure. So let's say your patient's going through chemotherapy and they're going to have photobiomodulation treatment for that. That's a covered benefit for many medical insurance plans. There's an excellent systematic review on how Tylenol and Advil together are found more effective. Yes, we've got that link in the handout. You don't see the link for the quiz, but it's in your handout. And let me show you what page that is, and then I'll be giving you the code, because I want to make sure you all have it. If you reach out later asking me for the link, I'm going to be scratching my head wondering where we failed you. Okay, slide number 5. Quiz link is here. And I'm going to go ahead and put that handout for you so that you can, I will be giving you a passcode in 1 second. If you didn't get the handout, it is right here for you in the chat. I'm going to label it. I will have the passcode up here for 1 minute, and then we're closing down. So make sure that you write it down. Handout is there for you. And I'll go ahead and put the passcode on the screen. All right, passcode is 952561. Take a screenshot or write it down. We cannot provide it once the class adjourns. And if you need the handout, it's also available directly from the chat area. I just posted it as a PDF, okay? Once you have that passcode, you can go ahead and log out. And I'll leave it up here for a couple of minutes. Again, if you don't have it, later, I cannot provide it to you. That's part of the security, so make sure that you have it. Thanks so much for being here. Tomorrow night's course is on oral mucositis. We have an infection control class this Saturday. I'm also presenting a class on periodontal inflammation and systematic drivers. That will be Friday. So please check with the website. Passcode again, 952561. 952561. I will also put it in the chat area. Quiz is page 5 of the handout. If you need the handout, tap on that red banner at the top of the screen. Quiz is page 5 of your handout. If I have a patient that's not able to take Tylenol or NSAIDs, non-pharmacological only, I'm looking at using photobiomodulation. I'll precondition the area first. I haven't had that happen yet, but Lori, do you have the handout? The quiz is on page 5 of the handout. The link, page 5, where it says quiz link. Page 5 of your handout, CE credit instructions, quiz link here. If you can't access it, it's probably device related. So write down the passcode and maybe try a different device if it's not working on your phone, but the link's working fine. And we already have about 300 that took the quiz. So make sure you just try it on a different device. Download the handout. Make sure that you have the passcode. Again, the link is in the handout there. The quiz is in your handout. So the quiz is not going to be up here. This is the passcode that I'm going to take down in about 30 seconds. So write down the passcode 952561. All right, everyone, thanks for being here, and we'll talk to you soon. Good night now.